Welcome to Marrow Masters, sponsored by the National Bone Marrow Transplant Link, Insight Corporation, and our esteemed Link partners. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow and stem cell transplants from diagnosis through survivorship. This season of Marrow Masters focuses on chronic graft versus host disease, or GVHD. Here's your host, Executive Director of the NBMT Link, Peggy Burkhardt.
Today we are back with Dr. Joseph Uberti of the Karmanos Cancer Center in Detroit. We are going to discuss current and new treatment options and moving forward with chronic graft versus host disease. Welcome, Dr. Uberti.
Thank you very much for inviting me, Peggy. Glad to be here.
So what are the current standard treatment options for chronic graft versus host disease?
Well, if you look at the treatment options for graft versus host disease, I think first you have to think about what's causing it. And remember, the cause of graft versus host disease, whether it's acute or not, is that the donor cells are somehow attacking your body and tissues in your body. So you have to find a way of stopping your donor cells, and specifically the T lymphocytes and B lymphocytes of the donor, from attacking various organs of your body. So the treatment options usually consist of medications that block the activation of the T and B lymphocytes from your donor against the patient. So how do we do this? Well, most of the drugs we use are drugs which we know and sometimes use to treat acute graft versus host disease. So one of the first treatment options usually is we add the steroids to the treatment that we have the patient on. So most patients, when they get chronic graft versus host disease, are usually on a calcineurin inhibitor, and that's usually either tacrolimus or cyclosporin. The first option, once we've seen signs and symptoms of chronic graft versus host disease, is to add steroids to it, or salumedrol or prednisone. Now, as you know, these drugs are very powerful drugs and really sometimes are the first line of therapy we use for chronic graft versus host disease. Steroids are obviously a mixed blessing for our patients. They do have a good effect in treating graft versus host disease, but there are a tremendous number of side effects that are associated with them. And sometimes we have to weigh the benefit of any drug we use with the side effects that often accompany them. As an example, steroids can cause muscle weakness, they can cause diabetes, they can cause changes in emotional ability. So there are a lot of complications associated with steroids. They sometimes increase your risk of infections, and other complications do occur with it, such as bone loss and other things that are well known to be a cause from the steroids we use for the treatment. What other options we have for the patient depends on how you decide to respond to first-line therapy. If you do respond very well to first-line therapy, then sometimes we can just get by on steroids and maybe a calcineurin inhibitor, and we try to decrease this over time. So the way we taper the steroids usually requires a long taper, which can occur over months or years, where we don't want to see a flare of the graft versus host disease and where we want to minimize some of the side effects of the steroids. Now, how aggressively we treat graft versus host disease depends on how it comes on in the chronic phase also. If it comes on very aggressively, we may add very high-dose steroids. If it comes on not so aggressively, we may add lower doses of steroids to try to minimize some of the symptoms. Occasionally, we have a situation of chronic graft versus host disease, as an example, where it just involves the mouth. If the patient's very symptomatic from mouth pain from chronic graft versus host disease, sometimes we can use mouthwashes that contain steroids without swallowing the medications, which sometimes prevents some of the side effects of the systemic absorption of steroids. So much of what we do usually entails steroids as the first option for graft versus host disease. It's not the only option we have, but traditionally it's been the first option we use to treat chronic graft versus host disease. How much we use and where we use it and how we use it really depends on how it evolves in the patients. Another example, sometimes the patients have skin changes that are very localized in chronic graft versus host disease. We can sometimes use lotions that have high-dose steroids in them, avoid some of the side effects of the systemic administration of steroids, and still benefit the skin treatment for chronic graft versus host disease. That can be used if there's only minimal involvement of the skin and it's not involving a large portion of the skin.
Dr. Uberti, there's so much excitement on new treatment options. What can you say about what's on the horizon and what has been recently introduced and the difference it may be making for patients?
There have been several new treatment options that have actually been approved by the Food and Drug Administration for the treatment of chronic graft versus host disease. And these have been the only two drugs approved by the FDA for chronic graft versus host disease. But before I get to that, I would just want to talk about some other treatment options that have been recent not approved by the Food and Drug Administration, but have been used for the treatment of graft versus host disease. One of those is called Extracorporeal Photophoresis, or ECP for short. What that is that the patient comes into our clinics, they go on a machine that takes their lymphocytes out. We treat their lymphocytes with an agent that deactivates the lymphocytes and give it back to the patient. That's called ECP for short. The patient has to come to our center, or a center who does this is on the machine for about 4 hours, and we usually do it 2 days in a row every couple of weeks. That is one of the treatments we often use for chronic graft versus host disease, especially when it involves the skin. Now, that may require a long-term treatment. Some of our patients have been on this treatment for a number of years, 3, 4, 5, even 6 or 7 years. But it does seem to treat many of our patients and keep the disease under control for many years. It is usually done in patients who don't respond well to the initial treatment, which is usually steroids, and may be added with a number of other agents we use. The other agent we've traditionally used for chronic graft versus host disease is Rituxin. Now, Rituxin is an IV medication. It's usually given once a week as an outpatient for 4 weeks, and it's often used in the treatment of chronic graft versus host disease, as well as ECP in patients who haven't responded to steroids. Now, neither of these two options treat all of our patients, but there's a fair number of patients who do respond to either ECP or Rituxin. Now, Rituxin is a drug that's been approved for many indications, and we use it for many malignancies and other types of diseases, but it has been effective in chronic graft versus host disease. And what it does, it's an antibody that targets B cells, which are thought to be important in the development and the pathophysiology of graft versus host disease. So by eliminating the B cells by the use of this medication, sometimes we can bring chronic graft versus host disease under control. Those have been two of the major therapies we've used in patients who haven't responded as well as we'd like to medications that traditionally we've used, such as steroids. The most two recent drugs that have been approved by the Food and Drug Administration for the treatment of chronic graft versus host disease are Ruxilinadip, which is also known as Jakafi, and Ibrutinib, also going by the name Imbruvica. Now, both of these drugs, again, are the only drugs approved for the treatment of chronic graft versus host disease. They work by different mechanisms, but we use them in the same way in terms of using them after patients have failed some of the standard therapies. They're both oral medications. They have very few side effects. There are some side effects associated with them, but I think there are far less than some of the side effects we see in patients with steroids. So sometimes they're added with steroids and some of the other medications we use. Sometimes they're added in replacement of steroids or some of the other medications we use. But it has been shown to be successful in several clinical trials of decreasing the incidence and the intensity of chronic graft versus host disease. So we have used these more recently for the treatment of graft versus host disease. Now, how you'll respond to this is difficult to say in any individual patient, but about 30 to 40 to 50% of our patients usually respond to this treatment. It sometimes does not completely eliminate the chronic graft versus host disease, but sometimes it does decrease the signs and the symptoms of the chronic graft versus host disease, and perhaps more importantly, allows us to decrease some of the steroids, which cause much of the side effects our patients get. So these are the newest treatment options for graft versus host disease that have been approved by the FDA. There are a number of other agents we use, and really how we use them depends on the signs and symptoms patients are having and how they respond and how much toxicity they're having to the current agents we're using. And all of them are out there. None of them are really beneficial in all of our patients. So basically, it's trial and error in using some of these medications in terms of how we treat chronic graft versus host disease.
What do you think of all of the clinical trials that are available for chronic graft versus host disease, and any advice on finding one?
Well, obviously, we need better treatments for graft versus host disease because we are unable to cure it in many of our patients. Although we usually can bring it under control, cure is sometimes elusive in many of our patients. So we do need clinical trials to try to really find a cure for chronic graft versus host disease. And that's why it's important to try to develop clinical trials and to have our patients being involved in clinical trials. Now, many of these are used as part of upfront therapy nowadays because we really want to try to treat chronic graft versus host disease much earlier, a little bit more aggressively, because we think sometimes if we do that, we're better able to get the disease under control and completely eliminate it. So many of our trials are used in the newly diagnosed chronic graft versus host disease patient because we want to try to eliminate it as quickly as possible and try to prevent some of the long-term complications that occur with it. So very often these new clinical trials include some of the standard treatment we use, plus a new agent to see if our standard treatment plus a new agent does better than standard treatments alone. The way we make advances in the treatment of chronic graft versus host disease is to have our patients involved in clinical trials. We try very hard to have clinical trials available for patients with many types and stages of chronic graft versus host disease, so we can meet the requirements of trying to find new therapies for patients with different types of chronic graft versus host disease. Many of these clinical trials are using agents that are already approved for other indications, so the agents we use for chronic graft versus host disease we feel are usually safe for our patients, but certainly we do watch for potential side effects when we try to add a new agent for the treatment of chronic graft versus host disease. This is the only way we will be able to really have a better way of treating graft versus host disease if we have patients who go on to clinical trials. We know it's a burden on patients. We know it sometimes requires them to have more visits at their referring physicians who's taking care of them, but we really think this is very important in doing research to improve the outcome.
Thank you so much. We get so many questions about clinical trials, and this is going to be very helpful to people. Do you think that the research out there is increasing treatment options?
I think we've had tremendous improvement in treatment options, and the two most recently approved drugs, Ruxilinadip and ibrutinib, are two examples of how we've got new therapies for chronic graft versus host disease because we've had patients who've gone on clinical trials to try to develop these new therapies. So it's two great examples of how clinical trials have improved our treatment of chronic graft versus host disease. And that's why it's important to try to find these trials, try to go to places who have these trials to try to develop better treatments. Again, it is difficult sometimes for patients to go on these trials, but I do encourage patients to talk to their doctors to see what clinical trials are available and see what may fit their symptoms and signs of chronic graft versus host disease.
I know that the National Institute of Health has a free clinic for chronic graft versus host disease. It's led by Dr. Steve Pavletic, who is a world-renowned expert on chronic graft versus host disease. Do you know about this, and can you add anything to this wonderful program?
So Dr. Pavletic has really developed a tremendous program in new treatment options for chronic graft versus host disease at the NIH. And the advantage for patients is that it's usually free for patients when they go there and when they can get into a program there. Not all patients have the type of graft versus host disease that can be treated under a clinical trial there, but I would urge patients if they're looking for new types of treatment and have the ability to get to Dr. Pavletic's clinical trials at the NIH, that's one area that they could look into to see if they would be eligible for the trials there. Again, the advantage is that doesn't cost a patient anything, and it may improve their outcome for chronic graft versus host disease. There are other clinical trials at other centers around the country, so really there are many centers other than the NIH who do participate in clinical trials, and sometimes we have group clinical trials that are run around the country that are available to patients at many of the centers that do transplant.
I know that Be the Match also has the Jason Carter Clinical Trial Department, and we've led patients to that as well. If anyone would like to know more about getting in touch with Dr. Steve Pavletic about this free clinic, they can contact the National Bone Marrow Transplant link. I would be happy to facilitate that. Dr. Uberti, is there anything else you'd like to add about treatment options and moving forward with chronic graft versus host disease?
Well, I think patients are frustrated with the treatment of chronic graft versus host disease because it's a very long, grueling sometimes experience for the patient. Very often we can't find the right combination of therapy at the first time we treat them. Sometimes we have to go through a number of therapies to find the best option for them in terms of treatment, minimizing some of the toxicities. I think one of the problems of chronic graft versus host disease is some of the therapies we use for them do have side effects. So very often what we're up against is managing the side effects as well as the benefit of the certain therapies we use. And we have to just try different things to kind of minimize the side effects while improving the therapy. It is very frustrating for patients because sometimes we have to go back and forth with different types of therapy. We have to try new therapies. We have to stop various therapies because of side effects. But it does require very much important involvement of your treating physician to get you through the signs and symptoms of chronic graft versus host disease.
I'd like to thank Dr. Joseph Uberti and the Karmanos Cancer Center, which is one of the 50 comprehensive cancer centers in the United States, for their time today and for being one of our link partners. Dr. Uberti is the director of hematology bone marrow transplant in the Detroit area.
Thank you very much, Peggy. It's been my pleasure being here.
This has been the Marrow Masters Podcast. Feel free to share this episode via social media, text, or email. To hear more, subscribe for free to Marrow Masters in your favorite podcast app. To learn more about graft versus host disease and the resources available to patients and caregivers, check out the National Bone Marrow Transplant link at nbmtlink.org. That's nbmtlink.org, or just tap the link below in the show notes.